Welcome to this next session in the pediatric track, to clot or not to clot. So this should be fun. Moderating today, I'm Alex Robertson, over here from London. I'm the chief perfusionist at Great Ormond Street Hospital.
Hi, I'm Ashlyn Strickland. I'm a perfusionist at MUSC Sean Jenkins Children's Hospital.
And we have our first speaker this morning is Dr. Dominic Carollo. Dr. Carollo earned his medical degree here in Louisiana State in New Orleans, and he completed both his internship in internal medicine and residency in anesthesia at Oshner Clinic Foundation, also here in New Orleans. He's completed his pediatric anesthesia fellowship and subfellowship in congenital cardiac anesthesia at Children's National up in DC. And Dr. Carollo is board certified in anesthesiology in both adults and pediatrics. He's been on the staff since 2011 and has also serves as the Assistant Chief Medical Information Officer in anesthesia for the system, and his special clinical interest is for the anesthetic care of children and adults with congenital cardiac disease. Dom.
Well, how about now? I am loud enough, you definitely don't need this, but the recording is probably better. Okay, so I was gonna think, as I was sitting there, I was like, man, what literally just came a thought. I was like, I'm pretty thankful to all the perfusionists that have helped me in my training. The two in DC, the ones that were here at Oshner when I was a resident, Jerry and George in Children's National, and then I have my friend Wade Brewer, my friend Sarah, and all the perfusionists that just the teamwork that we've all worked together all these years and how important it is. And I'm really thankful for that. Okay. I just thought about that when I was sitting there, like how thankful I am. So I was told this would work, but I was lied to. Oh. I'll be using the mouse. All right. I have no disclosures except to say we're going to discuss some off-label use of some medications. As you know, in the peds world, that's pretty much every medication we're going to talk about. All right, just some objectives because I have to have objective slides, but most importantly, we're going to concentrate on the congenital heart surgery use of PCCs. So a little bit about me. Like I said, I'm from Chicago, and I think a good way to know a little bit about a person is what sports teams they're fans of. And as Americans, you know that we are very loyal to our cities we grew up in. So I'm a Bears, Cubs, Blackhawks fan. I would say Cubs are near and dear to my heart. And I'm really not looking forward to this season, as you can tell. But I went down to college at the University of Miami, and I became a huge Miami Hurricane fan, where I met my wife, and she's from this great city in Louisiana called New Orleans. And I decided I was going to become a New Orleans Pelicans fan. I've lived here about 25 years, and we have two lovely children, and my daughter, who's a sophomore at University of Georgia. So I now get to become a Georgia Bulldog fan because if you pay tuition there, you get to be a fan. That's for sure. Professionally, Alex did a great job of introducing me. Nothing else really to add. I do have mainly a pediatric CV practice, 10% general peds, a little bit of adults, but no adult cardiovascular. And then I'm a data nerd. I don't like to admit this to people in nationwide conferences, but I'm actually on the EPIC subspecialty steering board. I'm the assistant chair, and I'll be the chair next year for anesthesia. And that is where all the perfusion. So if you use EPIC perfusion, that came through the anesthesia section, which is something that I am very well aligned with. But so if there's any problems, you can blame me completely, just so you know. All right, who hates this image? We all do. I hate this image. I am not going to spend 25 minutes talking about this image. That is a guarantee. But the drugs that we are in both pathways, the intrinsic, the extrinsic pathway, and then, of course, the common pathway. And a lot of the drugs that we talk about today, we're going to talk about procoagulants and where they live in this pathway a little bit. All right, so allogenic blood product transfusion. It's our friend, right? Aren't blood products awesome? Not really, right? There's a lot of problems with blood products. We all know that. Of course, infection transmission, immunologic reactions. You can have lung injury requiring longer, prolonged ventilation, increased hospital stay. We all know that we try to love our blood products, but too much can be a bad thing. So, cardiopulmonary bypass by itself, aka surgery, increases the need for blood products. So, and we know that there is problems with what aspects of the cardiopulmonary bypass increase the need for blood products. So, of course, hemodilution by itself, it's the nature of what we do. We automatically hemodilute the patient. You have to. We were talking about kids with 380 mLs of blood volume and a circuit. At least our smallest circuit is 400 mLs. By definition, you are diluting the patient, and that increases the need for blood products itself. We know that the cardiopulmonary bypass machine increases fibrinolysis, so clot destruction, activation of the complement cascade, and of course, there's an increase in inflammation. So what's the data to support things that actually make interventions in children having cardiac surgery? And I'm going to step over here away from the mic. You'll still hear me. But the data is not great on any of these things. We do not have great data in the pediatric congenital world to say we have double-blind, randomized controlled studies. This way is better than that way. We just know some things that we all think, and we have some things that some studies that back that up. For example, one of the most powerful aspects that we know is right here, this prophylactic transfusion to avoid hemodilution. We know that if we keep the crit higher than, this says 20, but 25 is what I'm going to get to in the real pediatric data, that kids do better. That's pretty simple, right? Pretty simple type of thing. And the only other thing that shows that it actually has good randomized controlled studies, but there's no neonates in these studies, of course, is a restrictive transfusion practice. So the less blood products you give, the better off they do. All right. I am told by my family all the time to stay in my lane. I have never listened to my family. I never stay in my lane. I like to veer off course constantly. So I'm going to spend a couple minutes going out of my lane and sort of into your lane. So don't be mad at me, and talk about some transfusion reduction cardiopulmonary bypass strategies. Okay. So this is y'all's purview. This is perfusionists, where perfusionists and anesthesia and surgery all meet. We're all together. Of course, I harp on it. The normalization of hematocrit on cardiopulmonary bypass. Great studies show that keeping the crit above 25% has developmental effects on children and their outcomes. So on bypass, kids that have crits greater than 25 are developmentally more normal. It's important to understand that, right? And that data is pretty clear to me. And I know that most of you probably use that strategy to keep it, 23, 24, 25, 26, something like that. All right. Hemoconcentration techniques. So MUF versus continuous. Looks like when I dive into the data, remember anesthesia data, MUF is better. MUF, modified ultrafiltration, is better for removing cytokines and cytokines, and better at reducing and better at removing volume, and they do better outcome-wise. Now, my friend Chelsea is going to talk a little bit more about composition of your cardiopulmonary bypass prime, and that is not my topic of expertise. I want to be honest with you, but some good studies in the anesthesia literature talk about whole blood versus packed red blood cells. Man, who has access to whole blood? Yeah. Oh, wow. I want to work at what hospital are you at? 'Cause I want to come to your hospital, because we have no access to whole blood. All of our blood products are partitioned, at least at Ochsner Center in New Orleans. But there is some studies out there that show neonates do better with whole blood in their prime. And I think I thought they were well done studies when I reviewed them. FFP, pump prime has, of course, coagulation effects. Also helps with heparin sensitivity. And so some people use it, some people don't. Our strategy a little bit is sort of related to the slope in the HepCon and how sensitive the patients are showing to heparin once they get into the room. And there's no protocolized, every patient gets this in the prime. But it's also very institutional dependent. Ochsner is different than Children's, and they're 1.5 miles away from each other. All right. The last part of talking about this is of talking about the cardiopulmonary bypass strategies is profound hypothermia obviously has profound effects on coagulation, but be very clear on this. The neuroprotective effects of the hypothermia way outweigh the transfusion downsides. So the neuroprotective effects of being cold is more important than the fact that you actually have to give blood products. All right, I'm going to steer back into my lane. All right, we're going to talk. What they asked me to talk about was PCCs and prothrombin complex concentrates. I'm not saying those words again. It's just PCCs the rest of the talk. So I like to think about the story of how we got here. Who remembers Novo 7? Or maybe some people still use it. When I was a resident, this is like late 2009, 2008. Man, it felt like we were giving Novo 7 to a lot of these patients. Oh, they're bleeding too much. Let's go grab the Novo 7 and bring it down. And then something came out, I want to say 10 or 11. It was actually a video of profound thrombosis and then embolic events and strokes. And we were finding that we were having more thrombotic events than we really thought. And so we realized that the technology needs to get a little bit better. And I think that's where these PCCs came into being. So the definition of PCCs, they have 3-factor PCCs, which means they have 3 factors. It's really hard definitions here. 4-factor PCCs means they have 4 factors. And then FEIBA stands for factor VIII inhibitor bypass activator. But it's really just a 4-factor PCC that has some activation effects. All right. This is a busy slide, but it's an important slide, okay? So I'm trying to show you here what are the different manufactured type of PCCs and what factors do they all contain. So these are all the factor 4, but they all contain 2, 7, 9, and 10, right? The vitamin K dependent coagulation factors, all right? And then some of them have heparin, some of them have protein C or protein S, and some of them are activated and some are not activated. And so it's important to understand the one I use the most and the one that I have the most experience with is KCentra. That is the one that's available to me at my institution. So when I talk about my experience, I am literally only talking about KCentra, okay? So my interaction with FEIBA is all in the literature and in the world and in the research. But notice it has traces of thrombin, activated factor 9, and factor 10. Okay, so it's activated versus the other ones are inactivated and need your native coagulation cascade to be activated. The advantage, and I want to be really clear on one other thing of these 3, is that they have protein C and protein S within them. Okay? Which, if I have to remind everyone, that's this little thing in the down corner over here that helps with activation. All right. How did we get to the PCCs? Well, the hemophiliacs helped us get there, okay? Hemophiliacs were getting lots of blood products to be able to anytime they'd have a bleed or anytime they'd have a big bruise. And they were getting so overexposed to blood products that their life expectancy was decreased. And they decided that research decided that they needed to find a way to be able to better support them with these synthetic factors. And that's how we got here. And that's how we started with most, and that's where most of these things are FDA approved. So we have these PCCs because of the hemophiliacs. That's why they're FDA approved. The secondary use that we really have these PCCs for is for the reversal of Coumadin or vitamin K dependent anticoagulation in emergencies. So when your iron is elevated to to high levels, PCCs are approved for the reversal of that coagulation. And in fact, in the UK, PCCs are more preferred over FFP in reversing this condition. I don't think that happened in the US yet, or not at least that I've seen. Okay. So to the meat of the issue, post-cardiopulmonary bypass bleeding. So you've given FFP on pump. We give our FFP while we're rewarming just to give some, 10 to 15 per kilo. After heparin reversal with protamine and your ACT is normalized, I want to just talk a quick little section on that is that the data does seem to show to me that if it's protocolized, it's good. If you use the HepCon and it's protocolized, it's good. What's not good is, as Alex would say, is putting the anesthesiologist putting their finger in the air and say the protamine dose is 12. That doesn't seem to be as good as the other ways. That wasn't a rip on y'all, Alex. I just wanted I thought that was funny the way you put it. So we treat the coagulopathy, platelets, cryo. Once they've been blood exposed, we tend to give that, talking about neonates, with balanced packed red blood cells. I like to try to be as balanced as possible, like 1:1 to maybe 0.5 of cryo, maybe sometimes additional FFP. And now we're still a little bleedy. Get a tag, and this is where PCC sort of come into play. A friend of mine was reviewing this talk with me, and she said something very important, Dom. She said, you need to make sure one thing is that everybody needs to commit to the anticoagulation or to the coagulation plan. How are you going to get this patient to start clotting, including the surgeon? So the surgeon the surgeon has to show a little bit of patience sometimes, because some PCCs, while they're rapid, they're not instant. Nothing is instant when it comes to coagulation, except what's instant is the surgeon taking the suction cath. I feel like I talk bad about surgeons in this room. The surgeon taking the suction right on top of the clot that was just formed and sucking it off. So it needs a new clot needs to form. Wait, don't tell Dr. Peeler. Okay. All right. How I actually give the drug. So as I told you, this is how, like literally how I actually give it is that once it's reversed with heparin, we give platelets and cryo slowly, and I give a third of my total dose of KCentra, which is, I'm going to eventually give 50 units per kilogram, all right? When I'm giving my Amicar or TXA, whatever y'all's choice is. And then I sort of wait a little bit from that point for the surgeon to say that he is pretty confident that we have resolved the surgical bleeding, okay? So pretty confident. My favorite thing to say to him is we have a factor 14 deficiency. Who knows what factor 14 is? It's proline. It's a proline deficiency. All right. And then once we have that, then I like to give the rest of my 50 per kilo dose, which is about 35 per kilo. And then if we're still having bleeding, then I'm checking a tag. I'm checking the lab values. I'm trying to be goal directed as much as possible. While I'm doing that, I'm also still supporting the patient with packed red blood cells, cryo, platelet, maybe even additional FFP while we're waiting for those labs to come back. The key to this all is constant communication between the surgeon, the perfusionist, the anesthesiologist, all working together to solve whatever the problem is. All right. I feel like I need to talk a little bit about the data. And so I didn't want to talk a lot about studies. I wanted to talk a little, like, bring you guys into this, but there is some decent data about the safety of PCCs. So this is a 2014 study, and it uses Confidence. Confidence is very similar to KCentra. They're on that same, it's not the same manufacturer, of course, but it's the same level of what the drugs are in there. I mean, the factors that are in it. So it's cohort controlled. So there's 14 patients they gave the PCC, and they compared it to 11 historical controlled patients. So not the best design of a study, but it's sort of what we get in the pediatric literature, is that we only get the studies that are historically controlled, because no one can do randomized double-blinded controlled studies. It's very difficult, in fact. All right. So the point of showing you this is that what they had was they had less bleeding in the confidence groups, and that all of the lab values were similar in both groups. And you can look through this, but just know that all of the lab values, nothing was statistically significant. So what the authors were saying is that it's safe. That's the first thing in pediatric, is we care about safety, right? Safety first. Less blood products were received in the PCC group, but it wasn't statistically significant. And of course, there's a lot of limitations when it gets to their sample size was 14, and they had a cohort control group. That's a very big limiting factor, and bells and whistles should go off in your head. All right. In my in the anesthesia literature, I found this little review of these are the best pediatric studies when it comes to PCCs. So instead of going through all of them individually, I thought, let me just put them up here, and I'm going to go through them pretty quickly because I don't want to bore you all with too many studies. All right, I went over Nori already. That's the first one. The second one is that Novartin, they gave heart liver transplants, PCCs, and they also gave them something like Amicar. And the patients, they also gave them Nomo7. So what it tells me about this study is that if you do a liver heart transplant combined, which I've never done, that they bleed a lot. And that doesn't surprise me. Okay. It sounds like they bleed a lot. It doesn't surprise me. It doesn't surprise anyone in this room that they bleed a lot. And they just throw the kitchen sink at them. And PCCs are part of that formula, and it's safe. All right. Rebecca, I thought it was a good study of like how they use the drug. So prospective cohort of 15 children, 9 months to 3 years, and they gave them varying doses between 30 and 50 mLs per kilo or units per kilo, and clinical hemostasis was achieved in most of their patients. Josti, they retrospective cohort comparison using neonates, but they also gave them factor 7 a lot, and they had a lot of thrombotic events. So to me, I haven't given factor 7 in, I don't think since the new surgeon has been here in 2016. We've only been using these PCCs. Maybe once or twice we did. So cysti, showing you that LVAD patients, that it's safe. The PCC use is safe. They're older patients, of course. And then, but this is the best study of this group to set the first one, is that they did a propensity score matching of 210 kids, and they compared FFP to PCC, and what they found was that the PCCs are safe in children and non-inferior to FFP. So making a case to y'all that PCCs are safe first. Is it better? No, I can't make that case to you. Do I think they work? Yes. All right. I thought this study was very well designed. It's an adult study, but it's recent. It's 2021. And so that's why I wanted to show it to y'all. Cardiac surgery patients, redos, all comers, randomized to say you're either going to get PCCs or FFP. And then the decision was made if you're actually going to give them either. So I thought that was an interesting little corollary, is that we don't give FFP and PCCs just to give it, right? And a lot of the early studies were just giving it to give it to see if it worked. Well, some of those kids are going to clot just with protamine, right? And so you don't necessarily need them. And I like this study because it's really more correlating to what we really do in real life. All right, so PCCs, FFP, and then we're going to see if they actually need it. And a good portion of each side didn't need anything. But they both, when you compare them, well matched, randomized, 42% lower blood product use in the PCC group, taking out the FFP portion. Hemoglobin was higher in the PCC group in initially 24 hours later and the next day, and 2 days later. The chest tube drainage was lower in the PCC group, and they had no adverse events. So just trying to show you again that this is the best study I've seen that PCCs might be superior to FFP. But do I know that in children? It's a hard case to make. All right, can't talk about PCCs without talking about money. FFP is pretty cheap in my hospital, maybe $350, $400. Obviously, as long as you don't have a transfusion reaction. This is the study that I could find, so published literature talking about it in for patients that they're reversing Coumadin overdose. In my hospital, the KCentra is $7,000 every time I give the 50 unit per kilo dose. So when you're talking about okay, 2 more minutes, 5 more minutes. I'm almost done. Known complications. Obviously, PCCs have known complications of deep vein thrombosis, stroke. I have not seen these complications personally, but they definitely happen. And then my last slide is just a general overview of, in the anesthesia literature, this is why PCCs might be better. All right. General efficacy, even in refractory coagulation disturbances. It is easy to prepare, and it's rapid to prepare. So when I call for the PCC, the KCentra, it is up in the OR in 15 minutes. The pharmacy does the dilution downstairs, in the pharmacy, but I literally have it in 15 minutes. And then it's low volume. I mean, it's literally 6 mLs to give 50 units per kilo to a 3 kilo child. It's versus giving FFP when I give 15 mLs per kilo, that's 45 mLs. That's a big difference in your entire blood volume. And obviously, we believe there is a limited risk of adverse events, and compared to when you give allogenic blood products. So there's no viral disease transmission, there's no trolley, there's no increased mechanical ventilation. All of those things are not possible with PCCs. Okay, there is my references. And then I will let Alex lead us forward. These are my children, Sarah and Dominic. And I will let Alex lead us into the discussion. Do I stay up here, Alex? I get to sit down. Thank you all very much.
Thank you very much for that. I followed almost all of it. And when anyone asks me about the clotting cascade, I just say it's multifactorial. And leave it at that. So do we have any questions or comments from the audience, first of all? Or should I lead this off? There's a few things that I've been jotting down. And I'm going to ask you about the use of TEGs and the various stages at which you do it. In our institution, we've got 2 generations of cardiac anesthesiologists. And the older generation say, I'll do a TEG if I need to after I've given all the round of clotting products because I'm going to do it. And the younger generation now insist on one while we're rewarming. So when would you say is the first time you should be doing a TEG, and when it's going to be most useful for you, how it guides your practice with this?
I would say, so that's man, you're going to make me put my dollar down. I like it. The first time I believe you should be using a TEG is, I guess I'm of the older generation now, which is crazy for me to think about, is after I've already going to give those products. I know I'm going to give those products, and then I give my PCCs. And then if I'm still having surgical bleeding, that is when I'm starting to get my TEG. The problem is the TEG is not instant as well. And I want to be like, it is the fastest you're going to get. It is, and it shows up on my screen in the operating room, and I can see everything that as it comes forward, but it still was 15 minutes ago. So even if you're doing it on the rewarm, you're still always 15 minutes behind or 20 minutes behind, and you have made other changes at that time. To me, the commitment to the TEG is that if you're going to be goal-directed, you're going to be goal-directed, and everyone has to be goal-directed, not just the anesthesiologist and the perfusionist. Everyone has to be a little bit patient, and that sometimes takes time to get the data, as long as the patient's stable, of course. Great question, though. Thank you.
Questions and comments?
One question: who uses PCCs right now? And I'm assuming a lot of people do PEDS. So I would say, looks like about 10%. Who's going to think about using PCCs after this talk or talk to their institution? Perfect. Nobody. No, I'm just kidding.
So just one more quick question from me, if you don't mind. You're talking about saving the volume that you're giving with the PCCs versus FFP as well. And that's key. You can't volume overload this neonatal heart after surgery, certainly. And earlier on in the talk, you mentioned modified ultrafiltration. And for me, that I come from the MUF institution, so I'm biased. I'll declare myself there. But that's, for me, is key. It's a volume neutral process, and it concentrates what clotting factors you have as well. So I'd be interested if just here's a show of hands. Who muffs here? Who doesn't muff? And keep your hand up if you used to muff but don't muff anymore. Okay. Does anyone have any comments on that in view of saving volume neutral process, concentrating clotting factors? And if you don't muff, are you now just sending it to the cell saver and throwing away all the yellow stuff? Great. Everyone agrees with me.
Yeah. We muff. I mean, so we muff, and I am a big believer in that look, I'm a simple man. When I see that our perfusionists are muffing, and I look back in that suction container, I see all this clear that's just now gone out of the system. Just makes me think that that patient's going to be a little bit happier. And I like the hematocrit to be a little bit higher. Yes, sir.
Thank you. If you could introduce yourself for the benefit of the audience, even though we all know who you are.
Vince Olshavy, Louisville, Kentucky. A great presentation.
Thank you.
And these are always interesting discussions at any meeting and certainly within our own institution. We do not muff. And one of the problems with muffing, and I won't say I'm necessarily upset about it, but it's interesting, your comment that you muff to save the factors, yet we go back and start slamming products in anyways, whether we muff or we don't muff. Which are some of the issues that present themselves. We happen to send a platelet count and a fibrinogen count and get an AT3 level when we're rewarming before we come off. So we have that as a starting point. Some of the anesthesiologists like TEGs. We were drawing them for everybody, but half of them weren't looking at it. So on those particular ones, we don't send them anymore and we wait until we're off. Our push has always been, and what we try to get the anesthesiologist to do and really try to get the surgeon on board has been the biggest training. And that is to typically what we find fibrinogen, you can give them all the platelets you want, but if they don't have the fibrinogen, clot just isn't going to form. So we really pay attention to that number, and it makes everybody happy because it's the smallest volume you're going to give anyways, going back to your volume comment. But I think one of the biggest challenges that we have is really, and you addressed it, but getting everybody on board. And we had a little bit of a discussion earlier, getting anesthesiologists to even standardize their practice within a given institution. Could you kind of comment on that maybe?
Sure. I want to comment on the first thing with the cryo. So I'm giving cryo to all these neonates. And the thing about what I've learned about cryo recently, and not recently, but what I feel like has been adjusted for me is that I used to, quote unquote, slam in the cryo no matter what. And I think that cryo has the most calcium binding properties of all of the blood products. And I do find that like slamming in cryo has not been a great thing for me in the past. And giving I feel like I need calcium a lot of times right afterwards. So I give it on infusion now, just saying that. So getting everyone on the same page. You're right. Me and my anesthesia, Wade will tell you right there, me and my two anesthesiologist partners, we were doing things very, very differently. And it takes the surgeon and the perfusionist to point that out because we never worked together. So except when he was coming on board, that he saw how I did it, really never saw how he did it. And so if the surgeon has a preference on, that had to come from him. And it did come from him probably in the last 2 or 3 months. And we are trying to be as close together as possible. Now, tag or no tag, I liked what you're saying about if you need to convince people to give cryo, then getting a fibrinogen level to help them convince to do that is important. But getting on the same page, it has to come from outside the anesthesiologist. And I think that drove us right now to be in a better place where we are more trying to do the exact same thing. Except, Wade, I'm not using the manifold, no matter how much Jake wants me to.
Okay. Ashlyn, are there any questions from online? Okay, so in the interest of time, I think we'll wrap it up there. Thank you very much, Dom. Very illuminating.
Okay, our next speaker is Chelsea Capone. She currently works at, oh Lord, I'm gonna butcher this, Dornbecker Children's Hospital, Portland, Oregon. She is a member of the Pediatric and Congenital Committee.
Sorry, everyone, just a second. Yeah, that's fine. Awesome. And I don't think that's working, is it? Yeah. It is? Right. Left. Laser pointer. Okay. Awesome. Somehow it's going to work for me. So I'm sorry about that. Thank you, Dr. Carollo. That was a great segue into my talk. And thank you for the wonderful introduction. So today, let's see if this works. I'm going to be talking about FFP. This comes from a survey that was sent out in September of 2023 last year. So I'm going to start with chatting about FFP use in pediatrics with some basic info about current standards, followed by a quick review. I promise I won't inundate any of you. And then we'll get to the survey. And then after the survey, we're going to get to a really fun part, and we're going to ask for all of your help with it. Okay, so just some basics. FFP is composed of plasma proteins and coag factors, fibrinogen, albumin, protein C and S, antithrombin, and immunoglobulins. Whew, that was a long one. It's obtained via whole blood donation or apheresis. Sorry, I'm trying to get this to work. Okay. Once thawed, and it needs to be transfused within 24 hours. And it's really important to note that clotting factors gradually decline 6 hours after thawed. So therefore, it's paramount to administer right after thawing. So why do we put FFP in the pump? Dr. Carollo kind of talked about this. And the first is just because. I've heard that so much, like just because we do it. We don't want to bleed after. Well, that's not a good enough reason. So the next reason is perioperative bleeding, which is a common complication in our patients. And it has two main causes: coagulopathy and lack of surgical hemostasis. We know we can't control the latter, no matter how much we want to. We've all been there. We sit there, we're watching bleed. We know it's the suture lines. So in terms of coagulopathy, low fibrinogen and an inadequate heparin reversal are important factors. Such bleeding is associated with hemodynamic instability, increased support, chest exploration, and increased transfusion requirements in the immediate post-bypass period. Many of our patients, especially neonates, have immature coag systems. It's not new to any of us in this room, which are responsible for quantitative and qualitative coag factor deficiencies. Cyanosis and CHF exacerbate these coag abnormalities: polycythemia, low fibrinogen, low clotting factor concentrations, low platelet count, and increased fibrinolysis, as Dr. Carollo talked about. Other risk factors are temperature fluctuations, duration of bypass, deep hypothermic circ arrest, and reduced sternotomies. Well, how do we combat this as perfusionists? We give FFP. This product helps maintain physiological, colloid oncotic pressure and prevent the development of dilutional coagulopathies. This helps prevent interstitial fluid accumulation and curtails bleeding. But as we all know, Dr. Carollo talked about, blood products are not good for our patients. Infection, transfusion-associated circulatory overload, trolley, citrate toxicity, thrombotic complications, these are all caused by blood products. And finally, cost and supply issues, which many of us experienced during the COVID crisis. These transfusions are one of the leading causes of morbidity and mortality, including renal failure, low cardiac output syndrome, and increased length of stay. And we use blood conservation techniques. We use circuit minimization, ANH, RAP. We've all done this to minimize prime and hemodilution, but blood, we still need it for some of our patients. We just can't get around it. According to the 2021 International Survey, FFP is used in the majority of neonatal circuits. As seen here, the rates are 63, 81, and 59% respectively in the neonatal population. And still, patients from 1 month to 1 year are still receiving FFP at high rates. So with the majority of ped centers priming with FFP, especially with the neonatal population, the efficacy of such clinical practice should be firmly established, right? Well, let's find out. This meta-analysis of 20 randomized controlled trials by Siemens et al. In 2022 established that FFP usage, its clinical implications, and dosing regimens are very diverse. As we see here, the amount of FFP, and I'm sorry, it's really busy and hard to see, so I apologize for that. So what you can, if you could actually see the slide, the amount of FFP added in the prime is variable from 150 to 300 mLs or 10 to 20 mLs per kilo if weight-based. No studies directly compared different dosing regimens, so there's no quantitative or dose evaluation. And none of these studies dosed FFP based on fibrinogen levels, functional fibrinogen levels from TAG, or COP. So from this slide, you can already start to see the variation in practice in pediatrics when it comes to FFP, or I wish you could see it. One article that I pulled out of there that I really want you guys to look closer at is this by Bianchi et al. It confirms that FFP use in the prime preserves post-op functional fibrinogen levels. As the largest randomized trial so far, the study tested the superiority of late versus early FFP dosing on bleeding and transfusions. It concluded, similar to the other studies, that patients over 10 kilograms did not exhibit any clinical superiority when they received FFP in their prime. However, patients under 10 kilos and those with cyanotic lesions definitely and significantly had more bleeding post-bypass when they didn't receive FFP in the prime. The results of the study suggest FFP should be used in the prime when we have patients with cyanotic lesions, complex heart defects, or less than 6 months. The authors also suggest exploring alternatives such as albumin, synthetic colloids, fibrinogen concentrates for patients instead of FFP. Not only do these substitutes maintain colloid osmotic pressure, but they also aid in limiting exposure to blood products and prevent fibrinogen absorption and platelet adhesion to the circuit. So this is just a continuation of the meta-analysis. So I'm not going to go through all this and inundate you, but there are several important conclusions that they came to. The first is that dosing regimens vary greatly in regards to FFP. There are varying degrees of FFP usage from centers that hardly use it to centers that use it for their prime and during bypass. There's truly no consensus. Different institutions utilize different dosing regimens with no strategy more effective than the other. The second is that FFP intervention, whether it is in the prime or on bypass, significantly increased fibrinogen levels, functional fibrinogen, immediately after heparin reversal. However, it was not sustained for 24 hours in the ICU. So similar to the dosing regimens, clinical implications are variable. The final conclusion is that data investigating FFP use for bypass is sparse and heterogeneous. It also showed that studies investigating FFP use suffer from small patient population, low quality data, and a high risk of bias due to insufficient reporting. Therefore, further studies need to be conducted to properly assess FFP intervention and dosing, as well as targeted fibrinogen therapy for the pediatric population. So outside of this meta-analysis, there are also many other studies that continue to support the variability in our FFP practice. The one I want to talk about is by Ranucci, because everyone knows Ranucci. So what he claims is that FFP can be safely substituted by albumin, gelatins, or crystalloids without the need for without increased bleeding and transfusion needs. What he states, which I thought was really interesting, is that an FFP strategy is neither inferior or non-inferior to an FFP-based strategy and vice versa. And he also argues that correction of low fibrinogen is better with a fibrinogen concentrate than FFP. Okay, these studies also highlight the overwhelming difference in dosing algorithms when it comes to FFP. Some just arbitrarily dose FFP for neonates, while some always use FFP when blood is added to the circuit. So that varies greatly. Some use tags or viscoelastographs. I know Ron told me to say viscoelastograph, but I'm going to say tag because it's easier for me, to identify at-risk patients, clarify mechanisms of coagulopathy, and determine FFP dosing. Others base their dosage on colloid osmotic pressure. There's really no consensus on what dosing algorithm is best, as one does not prove superior over the other. Without definitive data, FFP dosing algorithms are therefore predominantly driven by institutional protocols. So what have we learned from the literature so far? First, they all highlight important discrepancies within pediatric perfusion practice. There are variable strategies for FFP dosing, with none proving more effective than the other. The efficacy of FFP in the prime and during bypass are not clearly established, and more studies need to be conducted to establish these strategies to find the most effective way forward. But despite these conclusions in the literature, as we've seen, FFP continues to be frequently used in pediatric cardiac surgery. Okay, and now the fun part. Let's get to the survey. So in September of last year, Molly Bryant, who's PEDS lead at Mayo Clinic, posted the following questions about FFP to the Pediatric Fellows discussion board on the AMSECT website, and how the floodgates opened. Perfusionists from all over responded, and thank you for responding. This helps us so much. From Boston Children's to MUSC to Primary Children's to actually a lovely gentleman in Germany responded. So we had answers from everywhere. And drum roll, please. Here are the responses. Again, sorry, it's so hard to read. But these columns here, so these are the responding centers. This is if they use FFP in the prime, their kilogram cutoff, and then how much they put in the prime if they use FFP later in the case, and then any interesting comments that they had for us. Again, it's hard to see, but what was really interesting, no two centers were alike in any way. And these are big centers, big name centers that establish standards and guidelines for us. So some of the biggest differences is Rochester here, who never uses FFP, to CHOA and MUSC, who use FFP in their prime and later in bypass. Some centers used FFP prophylactically, like I said before, just because we just give it when we blood prime, to those who use TEGs and use TEG data to drive what blood products they give. So it is simple to conclude that there is a wide variation in perfusion practice when it comes to FFP. These patterns also become evident for PLN, and whoever in this room isn't familiar with PLN, get your center to sign up right away. That's my one plug. Here at the top, we see usage of FFP in prime. This is in mLs by weight, and this is percentages, and each one of these is individual centers. Although you can see these have been blinded, you can see usage varies significantly. And here's a breakdown of blood and FFP in the prime. Again, mLs in the left and percentage in the right. This is just the 3 to 6 demographic, but variability is still apparent. And thank you PLN members for sharing this with me. It's very useful. And so I come back to this slide. All of it stands true. The survey, the literature, PLN all show the variability of FFP use in clinical practice, with no strategy proving superior over the other. All right, now that I have all these blank stares in the room, I'm going to ask for some audience interaction. So I have polling up next to further our survey. So I don't think the surveys or the polling's going to work, so I apologize. I think everyone's going to have to raise their hand. And the whole point of this is not only ask questions, but to get discussion going. So we'd love to hear how your center uses FFP. And I will not be shy. If people don't talk, I will bring that microphone around the room. So just a fair warning. So the first question is do you routinely prime with FFP for neonates? Who's yes? All right, that's a lot of people. Okay, who's no? All right. And who's sometimes? Sometimes. And so how do you guys decide?
Hi, I'm Wade
Hi,
from
Wade.
Oxnard. So sometimes it's the first assist will do the scan and they'll just start pouring blood. So with that one, we might say, gosh, let's be aggressive with the FFP. They might just decide like on pre-bypass liver functions, like Dom will say, I think this guy's going to bleed. Would you prime with FFP? It's a case by case basis. Sometimes our slope is 30.
Okay.
And we would definitely put that in the prime. So it's, if we think that patient needs, we don't just treat every patient the same.
Okay, perfect. Anyone else? Ron, why don't you use FFP in Rochester? I know, I'm sorry. I know. I.
We just never have, 20 plus years. And I, like, why do you put FFP in the prime? For the colloid component or for the clotting component, right? The two things. The colloid component can be substituted with albumin or something,
Yep.
And I have just never bought into the idea that what you're doing 2 hours before you come off bypass has much relevance. If you're going to give FFP, I'm not opposed to it during the rewarm. We don't, but I can understand that rationale. But I don't understand when you're doing a Norwood, unless you're worried about heparin resistance. That's the other aspect too. But we give antithrombin on probably 10 or 20% of our cases. We have a ready supply of antithrombin. So we just really don't believe in it.
Okay. And once you're off bypass, if you have excessive bleeding,
We don't have excessive bleeding.
Oh, yeah.
Come watch. You used to work with me.
I know.
You knew the answer to that question.
I don't believe it. Okay. Great. And one of those studies, oh, sorry, go ahead.
I'll just reply quickly to Ron. I was in the same camp for many years, and I thought, why would you want to give clotting products into the pump when you don't want the blood to clot? That's not the time to be giving them. It doesn't make any sense. So I had that for years, but it was the Bianchi study that changed that for us, and anesthesia brought it to us, and we have evidence, and we've started using it as a result. So.
And one of those studies in the meta-analysis I thought was really interesting. So what they proved is that no FFP in the prime or during bypass helped with bleeding. Actually, the best way forward is after bypass, giving platelets and then cryo actually slowed the bleeding. Whereas if you gave platelets and then FFP, it actually worsened your coag panel. So I thought that was really interesting. Okay, so let's move on to the next one. This is where the polling would have really been useful. But what are the indications to add FFP to your prime? We'll just go down quickly. Raise hands. Weight. Okay. Age. Okay. Prophylactic with blood prime. Okay, a couple. Pre-bypass tag. Nobody. Oh, that's really interesting. Okay. For dilutional colloid osmotic pressure. Okay, got Daphne, got a couple. Okay. If you're circ arresting. Nobody? Okay. If it's a redo. Okay, got one there. Anesthesia or surgeon tells you to. Okay, yep. I figured that was going to be low AT3 levels. Okay. And then if your pre-op coag labs are all out of whack. How many people here have access to AT3 concentrate? Okay, and how many of you use it instead of FFP? One. Find that really interesting. So is it an access issue? Is it what the surgeon likes? Why do some of you use FFP instead of AT3? Anybody?
I think there's a couple, this is Daphne from MUSC. We tend to use FFP. I think it's cheaper, maybe not in the long run, but initially than AT3. Additionally, there's the COP component, and we reserve our AT3 when there's an AT3 deficiency.
Okay. And how do you determine the AT3 deficiency? Is it pre-op labs? Is it in the OR?
Our ACT is just not going above 300. But even then, if it's a neonate and we have a unit of FFP, typically a neonate 30 days less, we'll say, oh, well, we have FFP in the prime and we have 2,000 of units of heparin. We're going to go on. If it's usually an infant, a larger child, then we'll dose AT3.
Okay, thank you.
It just won't go on.
Yeah. Okay. Who measures baseline AT3. Thank you, Vince. All right, that's not a lot of people. So is that something you've always done, or is it just something you recently started doing, measuring AT3 levels? Pre-bypass, I know, I'm sorry. Sorry, one of you guys yeah. Huh? 5 minutes left, okay.
We started measuring it a couple of years ago.
Okay.
We do it routinely, partially because we were seeing issues with heparin and increased heparin dosing requirements. So we started measuring it as just part of our pre-op labs. And if they're low now, then we will dose it to the patient and the prime, or one or the other. And then we check a level on bypass, and we will redose again if necessary, so that they're set up when they leave the OR at a reasonable level.
Okay, great, thank you.
Around the University of Rochester, we would love to get, we just started getting pre-op AT3 levels. Would love to get it for every patient. The problem is a lot of the kids are coming from home, and we don't stick those kids the day before on their pre-op. So you get like a 4-month-old tet who went home and they're coming in. They don't really want to do that. So the kids who are in-house, any neonates that are in-house, we'll do that on the morning of labs and have a pre-op value, but not all the time. We sure could.
And that's kind of the same with us. We don't do pre-op labs, so we just go off the HMS in the morning. If it's showing us we have any value above 4.8, we dose AT3 either 50 or 100 per kilo, and then rerun the candy cane cartridge about 10 minutes later. All right, so how much FFP do you put in your prime? Is it weight-based? Okay, weight-based. Set ml amount. Okay. I don't do such craziness. Okay. Ron didn't even raise his hand for that one. And other. Okay, other. I would love to know what other is. See, I told you I'm going to call on people.
Hi, Madeline Del Children's. So we put blood and FFP in every circuit, certainly below 10 kilos. I think higher up, it gets a little bit more vague. But we will really look at what type of case we're doing, and we will adjust based on how cold we're going to go. How big the patient is also just factors into what size circuit we're using, but we really will try to tailor how much we're giving based on what the case we are doing. And we're really big on matching patient pre-bypass labs. We take one whenever each patient gets in the room. So we just match how well we can to every patient every day.
Awesome. And for those who do set ml amounts, how did you come to that determination of how many mLs to give? Is it a ratio of blood? Is it just a arbitrary number? Anybody wanna? No one? Okay. I guess my experience is that where I am now, we use the HMS, but before it was just an arbitrary number. If we put 200 mLs of blood in the prime, we put 100 of FFP, just did a 2-to-1 ratio. No science, no anything behind it. It was just arbitrary. Okay, if weight-based, what is your kilogram cutoff? And again, I'm sorry, I have to call on people, or you can just yell it out, please. 10, 5, 10, 8. Okay. I know this is like, so it's interesting. Is anyone above 10 kilograms? Okay, Jesse, what's your cutoff? 12? Okay. And is there a reason for it, or? Okay, stepping up to next circuit size. Gotcha. Okay, makes sense. So if you routinely give FFP on pump, when do you give it? Oh, sorry. Do you routinely give FFP on pump? So this is separate from prime. And if so, when? So do you give, hands up, do you give FFP on pump? Okay, who's no? Okay, who gives it on rewarm? Okay, and who's other? Okay. So, so what's other? During the whole case?
Jim Rager, Cincinnati Children's. So we'll usually try to squeeze it in actually before the rewarm. So after we get on, we'll get it in. there's some indication out there that if you give it while you're cold, that blunts the inflammatory effects when you give blood and blood products. So we try to get it all in early when we're cooling or when we're cold, rather than on the rewarm.
Okay, makes sense. That's great. Oh, do you guys? Oh,
Jess Montoya, UCSF Benioff. We give it right before clamp comes off, usually if we can, to try and lower our calcium levels to help with that. Because it's been proven that lower calcium levels when the clamp comes off has better effects on the patient's outcomes. So
interesting.
we try and use it as a calcium chelator.
And how much do you usually give
The rest of the unit.
rest of the unit? Okay. I hear that from a lot of people. Oh, we just give the rest of the unit. Okay, last question, I think, and then we're out of time. Okay. Okay. Who gives it both in prime and, well, on bypass for neonates? I should have. Okay. And again, one last question, sorry. Is that just to finish off the unit? Yes? Okay, awesome. Okay. Thank you. I had a bunch of other questions, but keep a lookout because I was hoping we could get all these answers and accumulate them, but you'll be getting surveys in your email. So please open, read. It helps us a lot on the pediatric committee. So thank you.
Thank you, Chelsea, and thank you, Don, to both our speakers for great presentations and also to the audience for a lively discussion. That's the end of this session, and I think the keynote presentation is happening now in the plenary session. Thank you, everyone.